In this episode, Watch Your Back, we're talking about musculoskeletal disorders, one of the biggest categories of workplace injury. We'll be talking about what they are, what causes them, and some of the innovative strategies from current research to try to reduce them. Almost every worker has had some contact with information about MSDs or experienced pain that may indicate a musculoskeletal problem. It's relevant to all workers doing all sorts of jobs with different equipment and tasks, from offices to coal mines, from fruit pickers to manufacturing plants. We usually refer to compensation statistics to get a sense of how many people suffer MSDs and what it costs. It's the biggest category of compensated injury in Australia. In 2016 to 2017, joint, ligament and muscle tendon injuries accounted for 41% of all serious workers' compensation claims, and musculoskeletal and connective tissue diseases accounted for 16%. So together, that's quite a proportion. The mechanism of injury is often referred to as body stressing, and this is most commonly in the back, shoulder, and knee. Body stressing was the mechanism in over 40,000 claims in that year, and that is a reduction in claims of over 27% compared to 2000 to 2001. The costs went up 107% in a similar period. There's also further work that looks more broadly at the impact of MSDs across the globe. A 2019 study by Ebag and colleagues found, using data from 183 countries in the WHO Global Health Estimates database, that
the burden of musculoskeletal disorders has increased significantly between 2000 and 2015, with musculoskeletal disorders being the second highest cause of years lived with disability worldwide. The top cause was mental and substance abuse disorders.
Dr. Robyn Coman is an expert in ergonomics and musculoskeletal disorders from the University of Wollongong. Robyn, you've worked as a physiotherapist and then later as an academic, and so you've seen lots of MSDs at the coalface, so to speak. What kinds of injuries are we talking about?
Okay, well, I've worked in the private practice sector as well as certainly in the hospital sector, outpatients, inpatients, and predominantly in work-related injuries, you would be seeing lower back and neck injuries, and then upper limb injuries, which could involve shoulder or elbow or the hand, the smaller structures of the hand.
So there's diversity in the kinds of injuries, and I guess that reflects that they're caused by all sorts of activities and tasks.
Correct, depending upon the stressors that the worker has been or the individual has been exposed to, will determine the structures that are injured. So, of course, in the lower back, that may involve the intervertebral disc, or it may involve the facet joints or other muscular structures. In neck pain, yes, there could be disc pathology, although that's usually to a lesser extent. It's often more that you have other structures involved, such as the neck structures of the neck and of the shoulder girdle. And we get things such as myofascial pain syndrome, where there could be multiple trigger points. They present with neck pain, but they've got multiple trigger points through the muscles of the neck and the shoulder girdle.
Okay. So often when we're talking about musculoskeletal disorders as an outcome, what we're talking about is manual handling as the nature of the task that's going on that relates to that outcome, right? Yes. Are we just talking about lifting of particular loads?
No, because we're talking about a hazardous manual task, and the definition of manual handling is, of course, any task that involves lifting, lowering, pushing, pulling, involving an object, animate or inanimate object. So that could be, of course, a box or a trolley, or it could be a person or an animal. So it's quite broad, the definition of manual handling and hazardous manual tasks as such.
So the training videos that most people would have seen where they give you someone lifting a box, that's not really representative of the kinds of tasks we're talking about.
No. So where training is, and we often use this, that sort of an analogy, you're given training where you're told how to safely lift a box. There's a number of points we should say. One, that manual tasks are quite complex. Rarely do they involve a straight lifting of a box. If you're moving loads such as that, often you may have to hold that load away from the body, which actually places greater load on the spine than if the load was close. You may be in a confined space, so you have to adopt an awkward posture to move that box. So yes, the tasks are very complex. The other thing I'd say is that we know that manual handling training as a single factor risk control intervention is ineffective in reducing injury incidents. Such training, if it's risk management based and part of a multifaceted approach to reducing the risks associated with manual handling, can be effective, can contribute to the effectiveness of the intervention.
Okay, so if training's not the answer, by itself at least,
yes,
what other control strategies should organisations be using?
Right, well, I'd say in the first instance, tasks need to be comprehensively evaluated. And you have tools such as the National Code of Practice for Hazardous Manual Tasks, which has been called up into legislation within New South Wales. Now, that particular Code of Practice provides you with a checklist, as an appendix within the Code of Practice, so that you can go through the checklist in your assessment of that particular manual task. If there are let's just say there's complexities within that manual task, other assessment tools are recommended. So you may go on to use some other ergonomic evaluation tools to enable you to comprehensively evaluate that task. So once you've undertaken that evaluation, you can then identify what risk factors is the worker exposed to. And here we're talking, physical risk factors in relation to the Code of Practice in particular. So is there force? Is there awkward posture? Is there repetition? These sort of factors, or is there a combination of them? And based on your evaluation of that hazardous manual task, you then need to implement risk control strategies, and you should do so in accordance with the hierarchy of risk controls. So you should always be aiming in the first instance to actually eliminate the manual task. Try to identify a way in which the workers do not have to perform the manual task at all. And if it can't be eliminated, then you need to be looking at, well, how can we redesign this task to reduce that worker's exposure to the risk factors that may result in injury?
So do you have an example of that kind of process where you'd go through the process of identifying the hazardous task and then figuring out what should be done to redesign that task or eliminate it?
Certainly. Well, one task that comes immediately to mind was a worker in a delicatessen in a major supermarket chain who had developed quite a serious pathology involving her shoulder. So when we went and evaluated her workstation, we found that all the meats, and you would have all been to a delicatessen in a supermarket, they were arranged in a display where it's glass fronted to the customer, but the worker had to reach a significant distance from their side of the counter to actually access many of the meats that were frequently required. And so we had to redesign the whole display of the meat so that the worker could comfortably stand in an upright posture. She could avoid having to flex her spine to reach the cold meats, and she could easily access them with a comfortable posture, and it reduced her risk exposure. And of course it made it safer for other workers who were working in the delicatessen.
Sure. And so the way that the products were displayed for marketing purposes.
Correct.
Was actually leading to an injury.
Correct, yeah.
So it was a simple redesign.
And it was a simple redesign of we had to, of course, put in and this is often the case when you put risk controls, you had to put a block such that they could not place things out in that zone, which was difficult for the worker to access it. Another example would be in the aged care sector, where I had to look at the handling of soiled linen bags. And the problem there was that the bags became very heavy. The workers had to take them off a stand and then drag them to the point where they could be sent off to the laundry. And we tried smaller bags, but the real solution was we actually ended up cutting off the base of the bag, actually making them quite small, such that they couldn't even push excess laundry into them, because that's what workers started to do. We tried to have smaller bags and then they stuffed them so full they were still a significant weight. So in the end we made them into very small, well, significantly smaller bags.
So you redesigned the bag.
You redesigned the bag so that the workers could only put the amount of laundry into them that was then able to be safely handled.
So that's quite a different approach to what people might normally think about in that kind of scenario, where, for example, they might say develop a procedure that instructs the workers
Correct.
to only fill the bags to a certain amount, which of course is never going to work.
It never works because, well, in the aged care context where I'd worked a lot, the carers have an extraordinary workload. So, they're trying to cover the ground and do all the showers and the care tasks for the residents. And if you said to them, only fill it up to this point, and they're racing down a hallway with a pile of dirty linen, of course they're going to keep stuffing it into the bag. Some hours hence they then have to move those bags.
Sure.
And then they're exposed to significant risk.
Often when we talk about musculoskeletal disorders, we talk about the contributing factors. And there's three main types: physical, organisational and psychosocial. What do we mean by those three different types? How do they work and how do they interact?
Okay, well, in terms of the physical demands, the four key risk factors would be repetition, force, posture and vibration, and a combination of those factors.
So what were they?
Repetition, force, posture, vibration, and a combination of those sort of factors. Psychosocial factors is where we're considering things such as mental work demands and job control, so the workplace organisational factors. And then we'd also think about the personal factors of an individual, so do they have any pre-existing musculoskeletal disorders and things that may affect their functional capacity. But look, an example I could give in terms of where you see a combination of this, let's say we've got a worker who's working at an electronic workstation, so they might be working a call centre, which is a very high risk environment. You may have absolutely optimised the physical aspects of that workstation, so they're sitting comfortably, you've got the physical ergonomics right in terms of the keyboard and the mouse input device, the screens directly in front of them. But when you start looking at the psychosocial risk factors, so they're under extreme workload, work pressures, they're often there is screens up above them which is saying there's this many calls waiting, and what happens then is that the worker may then get a physical response to those other stressors, such as increased muscle tension in their shoulder girdle in their neck, that can contribute to the development of musculoskeletal disorder. So in that case you'd say, well, we've actually optimised. I might say that, in some call centres, of course, there may be physical issues, but let's just say you've optimised it physically, but in fact, it's the psychosocial risk factors that are contributing to why the workers are developing neck and shoulder girdle pain.
That's great. I don't think that people necessarily think of call centres as high-risk areas. They just think, oh, well, they're not down a mine. But in fact, they can be exposed to quite serious things.
Call centres are quite high risk, in terms of injury incidents.
Maybe we can explore some of these issues with some examples from what you've been working on. You've done a lot of work on MSDs in the aged care industry. The Royal Commission on Aged Care Quality and Safety summarised some of the issues that distinguished aged care from some of the other services in the following way.
Aged care has a number of characteristics that both connect it to and separate it from other healthcare. Firstly, much of aged care is about social functioning. It is providing help needed to cope when physical and mental disabilities impair the capacity to perform everyday activities such as eating, bathing, dressing, shopping, and managing money. While these disabilities can be the consequence of diseases such as osteoporosis, cardiovascular illnesses, multiple sclerosis, and Alzheimer's disease, aged care has been principally about managing and reducing functional impairments, rather than managing disease processes. Thus, a great deal of aged care has tended not to involve highly technical medical services that need to be provided by physicians or registered nurses, and social services have been provided by relatively low-level trained staff members who account for the majority of paid carers.
Can you tell us a little bit about the nature of musculoskeletal disorders in aged care?
Okay. Well, for aged care workers, one of the principal tasks that they perform is the manual handling of people, which involves them performing care tasks with the residents. So this may be assisting them to move in bed, transferring from bed to chair, bed to wheelchair, also personal hygiene tasks, so bathing, showering and so forth. The problem with, and in the manual handling of people, we know that it is a hazardous task in response to the high incidence of injury amongst nurses and aged care workers. The approach that is taken in terms of risk control is minimal manual handling. And that means that we try to not lift all or most of a person's weight. So we try to use equipment and such like. Now, for aged care workers, principally their tasks are still the manual handling of people. They may have, well, they would always have equipment in an aged care facility, such as full lifters to assist them in lifting people. But their work is, let's just say the risk factors are further compounded by factors such as staffing. We know that there's the often insufficient staffing, so you've got workers who are having to continue to perform manual handling of people tasks across their entire shift. Then there are issues within the environment, such as access to the equipment. So it may be that the full lifter is at one end of the facility, they are at the other end of the facility. And I know care workers would often say to me, look, I'm sorry, Robyn, but I just did not have the time. I closed the door. I fully lifted the person out of the bed to the chair because I couldn't get to the other end of the facility to get that full lifter, exposing themselves to unacceptable risk. Now, in aged care, that's further compounded by the fact that you're dealing with residents who are often cognitively impaired. So you've got frail older adults, and you may have behaviours associated with their cognitive impairment, which makes it difficult for you to assist them. So they may be resistive as you're trying to assist them to get them out of bed, to even position a sling under them to lift them with a full lifter. So this further compounds the risk exposure for those workers.
So given how complex these aged care systems are, where would you start in terms of musculoskeletal disorder prevention in an aged care facility?
Right. Well, you need to have a multifaceted approach. So I think first you should consult what guidance publications are available. And there are some excellent publications, and I particularly direct students to the WorkSafe Victoria publications, one on the handling of people and the second on the design of hospitals, aged care and community facilities to optimise the handling of people. So then in terms of putting a multifaceted strategy together, it needs to be one that includes aspects such as provision of equipment. So that needs to be all forms of manual handling equipment, including furniture. So we want to have height adjustable beds, height adjustable chairs for the residents to use. The work environment needs to be evaluated and redesigned as necessary, because often there can be issues over confined space. Well, I shouldn't say confined space, that's another term, but limited space to enable carers to assist the resident in both the bedroom and the bathroom and the living environments. The system needs to also involve a risk assessment process for all risks within the facility, but also a resident manual handling assessment system where there is assessment and then the development of a manual handling plan that is easily accessed by the care staff and is revised on a regular basis as the resident's status changes. And this system also needs to involve policies and procedures in relation to the manual handling of people. And there should be, training needs to be a part of that then, and it should be risk management based. And I would say in the development of this approach to manual handling people in aged care, there must be involvement of staff. It has to be a participative approach.
When you say there about the training being risk management based,
Yes.
what do you mean there?
Right. Well,
How's that different?
Well, it's different to bringing workers in and just saying, okay, I'm going to show you how to assist a resident out of a chair or to reposition them in bed. You would start by talking to them about what is risk management. So what is a hazard, being something that could cause you harm, and what is a risk, the likelihood of occurring. And what do we do with that? We have to implement risk controls. So you start from that level. Then you would be asking the workers, can you tell us some hazards that exist in your work environment, and get them to start talking about, well, what are the risks associated with that? What could work? They might say, oh, well, look, they went and introduced some piece of equipment into the workplace. It never worked. We couldn't access it, or it broke quickly, or whatever.
So it includes some consultation?
Absolutely. And helping the work, because you need the workers to be able to be part of the process of identifying the hazards and coming up with the solutions.
Sure.
And that needs to be ongoing.
And so it's a bit more active in terms of the training. It's
Correct.
It's more active and
Yes.
collaborative, and it's getting them to understand what the hazards are, so that when they approach something that's new,
Indeed.
they have some skills.
Indeed, yeah. And that training, you would want to involve not just the care staff, but others who work in the aged care facility. And here I'm considering the maintenance staff, the cleaning staff. They all need to be part of that consultation process, because if you decide, okay, we're going to implement a particular type of patient hoist, but there may be issues in terms of using it with a particular bed, or issues that
Sure.
may impact upon cleaning staff or on those who have to maintain that equipment.
But also risk management based training in relation to manual handling or musculoskeletal disorders doesn't just apply to aged care. That kind of training could be used anywhere, right?
Anywhere. Well, that should be the approach taken anywhere. I suppose the aged care sector, we're discussing that because it's an area
Yeah.
that I've been particularly involved with, but it should apply anywhere.
So instead of just doing training in this is how you should lift this thing and putting a notice on the notice board, the training should be, here's how you identify the hazard, here's what
Yes.
you should do about it, here's what you should do if you think that the risk is higher.
Indeed.
Right. So
So you want the workers, well, one, you want them to have the knowledge of what is a hazard and a risk, and the sort of risk controls that be implemented, and also, particularly to give them an understanding of the hierarchy of risk controls, but also for them to develop risk control strategies and see that they were implemented, because then that demonstrates that management are truly committed to the safety of their workers. Because I think often workers will say, oh, they just keep throwing training at us. And we try to suggest things that are never implemented.
So if you had a magic wand, it's a bit of a hypothetical, but if you had a magic wand and you could fix MSDs in workplaces, what would you be doing?
Well, I would want to see that they have systems in place whereby all work tasks are optimally designed. So that will require that you've got participation of the workers certainly in the implementation, in the purchase and the implementation of any new plan and procedures, and that you are evaluating those work tasks at the outset. That's what would be the ideal.
So essentially, a really well implemented risk management system.
Correct, because if you're assessing it, it's got to be more cost effective to actually be assessing things from the outset, looking at the risk factors that a worker may be exposed to if they're having to use that equipment and interact in that particular interface, that man-machine interface, and to purchase the right equipment in the first instance, but if not, to redesign it so that it reduces the risk exposure as much as is reasonably practicable, but to do so from the outset. But also to have systems in place whereby staff can report those issues. They can report hazards. And those hazards, which should be not just physical, they should be able to report psychosocial risk factors such as workload. And
Sure.
and I say that to, I've said it to workers in my professional practice as well as to students. Don't just think you should be reporting water on the floor or a broken piece of plant. You should also be reporting factors such as workload that are impacting upon you